Well, hello. Very nice to see all of you, and, welcome. I have to say, that was a hard act to follow. Wow. Not only was there the science and the content, there was the delivery. I think that Dr. Roof missed his calling and could have really, been on stage, maybe as a comic. And I will say that in the world of narcolepsy, that's a useful skill. I'll add, it's a skill I don't have, but it's a useful skill because in years gone by, we were very interested in developing a cataplexy triggering test. And we tried different things, and we all wished that we had the skills of a stand-up comedian so that we could go into a room and tell tasteful, funny, shocking jokes that then would cause cataplexy. We would know the diagnosis, and off we would go. I lack that skill set. We did actually do some research, and for those of you who've been coming to this meeting for a long time, at a meeting in Seattle, back in the mists of time, I talked more about that study. In the end, we used videotape material, bloopers, to try and trigger cataplexy. It never really worked that well, but I think that we now know who to call upon to do the next version of that work. Well, with that, let me say I am delighted to be here, but this is a strange situation for me because you just heard a presentation with data that many sleep specialists don't know. So you just finished your fellowship in sleep medicine. And now I'm going to take you back, because this was my assignment, to the basics. So this is kind of flipped. But personally, when I'm learning something new, I sometimes like to flip things, where the complicated stuff I sort of get a sense of, and then I need to go back and make sure I have a good enough foundation to understand and revisit the complicated stuff. And the slides are available. So for those of you who heard that wonderful lecture and say, wow, that was a little hard to absorb, perhaps the information I'm going to share with you now will be helpful. And I do have some redundancy towards the end of my talk. I'll sort of be paying attention to the signals as to how timing goes. I know Amy went off to the advocacy talk, so she won't be giving me the signals, but I assume someone will be. So let's take it from here. So here we go, back to the basics. So my objectives are to help all of us understand the types of sleep disorders that are put into one big bucket. And those are the central disorders of hypersomnolence. And let me just take a moment to talk about why we call the bucket that. So there is a classification of sleep disorders called the International Classification of Sleep Disorders, and we're now on version 3. And we do have to lump things a little bit to just help provide a framework for clinicians, for patients, for insurers, for scientists. And the bucket that the disorders that the Narcolepsy Network advocates for is this bucket. And we call it central disorders because we're trying to sort it out from people who have excessive daytime sleepiness, an important symptom, but that's related to something else, like obstructive sleep apnea, or in less common cases, insomnia or restless legs. And so the 3 disorders that this organization champions, narcolepsy with cataplexy, narcolepsy without cataplexy, and idiopathic hypersomnia, belong in this bucket. And I'm going to take this time to talk about the key symptoms, to review the really basics of treatment, and there will be other presentations during this meeting that will go into much more detail. I'm just going to sort of point you in the right direction here. And then to go through some of the pathophysiology, but I may do that in a light-handed way because we just had the master talk, and that's all quite, well, I'll do what I can given the time available. So some of this you just heard. It's a challenge. We know people are living their lives with narcolepsy and idiopathic hypersomnia who have been undiagnosed, and it can be hard to detect. I had a patient who I saw within the last few weeks, brand new diagnosis, in his case of idiopathic hypersomnia, and he's a productive, high-achieving guy. He's actually in medical school, and he has somehow just toughed it out to finish high school, to finish college, to get into medical school, but this is where the wheels have started to wobble. And so he saw a physician who said, you know, I wonder, you've got such clear symptoms of sleepiness and there doesn't seem to be another cause. Perhaps you should go see the sleep team. And so we tested him, and indeed, this young man, and I think this has gone on for a while, has been living with idiopathic hypersomnia, and now we have him on treatment. And in his case, nothing fancy. And boy, oh boy, does he say life has gotten easier for him. But he probably should have been diagnosed 10 years earlier. And so this problem still continues. And in part, it's because our tests aren't great. And I hope in a few years, we'll be able to say, look at where we're now. The tests we used to use are now outdated because we have better tests. And he can be, this patient is an excellent illustration of how he has, through true grit, been able to pursue his dreams. But I think he's working harder than most of his classmates because he's had untreated IH. And he's been facing an impediment that his friends and peers don't have. And he has managed to continue to perform, although I think it's been really hard. And he, you know, it's very easy for people to start to fall away and not be able to perform adequately in school, in a job, or even in relationships. And then the one thing that came up in the last presentation is we worry that especially if someone's undiagnosed and untreated, that they may have a higher burden of coexisting medical problems because of their untreated central disorder of hypersomnolence. So, you know, what does a patient who's undiagnosed face? Well, they can fall asleep inappropriately. That can happen during classes, during meetings, for people who, let's say, have a job where they're supposed to be paying attention, and this comes up in the military context. It can be really tough that they're just not able to do what's expected of them, and it's viewed that they are irresponsible or careless when in fact it's not a choice. They can fall asleep during meals, during medical appointments. I've certainly had people fall asleep on me, and I take that as a data point. Something is amiss here. While driving, during arguments, and then during romance. Well, that's not very good for a relationship. Now, we have to be careful that people with obstructive sleep apnea also can have disorders of inappropriate sleepiness. So we have to first exclude things like that before we start saying, I wonder if it's a central disorder like narcolepsy. Now, there's some interesting data to sort of measure the sleepiness. This is just to show how do untreated patients with narcolepsy compare to a typical patient with sleep apnea. And I have to say, there aren't many typical patients with sleep apnea. It comes in many different flavors. But you can see here on this driving simulator test that the patient with narcolepsy had a higher burden of excessive daytime sleepiness than their counterpart with sleep apnea, and certainly with their counterpart who lacked either disorder. So I'll be talking about the basics here, and I'm going to go into some detail that you did not hear earlier. Just how does narcolepsy differ from IH? And my suspicion is many of you will be familiar with this, but my job was to go over the basics, so I will do my job. I will say that people with narcolepsy often feel a little bit of relief because their disorder has been better studied and is better understood. And Dr. Roof went into this, that we really don't know what causes idiopathic hypersomnia, and even to a degree, narcolepsy type 2. But we do know more about narcolepsy type 1, and this is where his elegant talk comes into play. There is a debate. Does narcolepsy type 2, is it more like narcolepsy type 1? Or is it more like idiopathic hypersomnia? And I can't answer that debate, but I know that it's something that is important because we often will select medicines based on a person's symptoms, and we like to sort of lump diagnoses. So I'm going to give you a whirlwind tour of the three main diagnoses that fall into this central category. The first you probably have heard more about because we know more, and that is narcolepsy with cataplexy, also known as type 1. And the symptoms are sleepiness. Well, that's across the board. Cataplexy, which I'll go into a little more information about. Sleep paralysis for some. Extreme dreaming for some. And disturbed nighttime sleep, a symptom that does not always get as much attention, but is very important, especially when you're talking about treatment options. We do believe that in addition to the information you already heard about orexin and hypocretin, that this is fundamentally a disorder of dreaming, of REM sleep. It shows up where it doesn't belong. It shows up during the day, and that's actually what cataplexy is. And it shows up too early and more frequently at night with a different pattern. Cataplexy is a sudden episode of muscle weakness triggered most often by emotion. So this is where, being a comedian would be a great skill to have. Because if a person can tell a surprising, clever, funny joke, cataplexy can happen. Now, my one little technique is I sometimes will say when a couple come in that I ask the spouse to tell a joke that, means something special to the patient. And once I had a couple in, and the wife was the one with the narcolepsy type 1, and she was pretty severely affected. And it wasn't a joke that meant anything to me. Her husband said, "Remember New York." And she would have cataplexy. I have no idea what was special about New York, but clearly that evoked an emotion, hopefully a positive, funny emotion, but that's all it took. And later in the hour, he said it again, "Remember New York." And indeed, she had cataplexy again. So there was some hidden, shared experience that the two had, but it allowed me to observe the cataplexy, and I often will then quickly reach over and test reflexes, because during cataplexy, as in REM sleep, a person briefly lacks the ability to have the automatic response when this tendon or the arm tendon is touched, where the stimulation doesn't go all the way up to the brain, just goes to the spinal cord and back, and a person has a reflex. That is absent during cataplexy, and it's a very useful test for a knowledgeable physician in the right place at the right time to confirm cataplexy. And in my opinion, all of the rest of the diagnostic testing isn't as important, because that's a pretty clear confirmation. However, an insurance company probably would want a little more than that. Cataplexy should be observable. Now, it can be quite subtle. I mean, I had another patient who was just telling me about her cataplexy, and it was mostly in her eyelids and her face. So it was subtle. And if a person didn't know what to look for, they may not have recognized that her eye blinking was actually muscle weakness. But there should be some objective sign of cataplexy, and it usually develops after a person becomes sleepy, but not too long after. Now, of course, there are exceptions. There are reports of people having sleepiness and then 14 years later developing cataplexy. So that, there always are exceptions, but usually the two go together. And when I meet patients who are teenagers who not long before developed narcolepsy type 1, they often will say, "Yeah, I was always a little more sleepy than my siblings, than my friends, and then I was on the playground and somebody spooked me and I was surprised and I fell off the monkey bars." And they have them develop in a fairly close period of time. We use the emotional trigger, but it's not always possible to employ it when a person is with you. So it's pretty rare for a doctor to see cataplexy. I've seen it quite a few times, but I probably have an unusual practice where I see a lot of people with narcolepsy, and I see a lot of people who sadly aren't well treated. If I take the patients I know well where they're on effective treatment, I can be as good a comedian as I possibly could be, and I won't trigger cataplexy because they're treated. And that's what we want. So it isn't that common that a person has cataplexy in a doctor's office. And there are a lot of well-experienced sleep doctors who've never seen it. Sleep paralysis, much less common. It is a transient inability to move as a person is falling asleep or waking up. And what it is, a little bit of REM sleep. Paralysis is common in REM sleep, occurring when it doesn't belong as a person's getting to sleep or waking up. Patients are conscious, so this is a pretty upsetting experience for a patient. This lasts longer than cataplexy. Cataplexy is often 30 seconds to 1 minute. Another reason it's hard to see, because it's often over not long after it began. Well, sleep paralysis happens and lasts longer, and sometimes we'll be doing a sleep study with an untreated patient, and they will have sleep paralysis while they're having their polysomnogram. There's not much shows up on video, but the patient will later tell one of our technicians, when I wasn't moving there, that was an episode of sleep paralysis, and if we go back and look carefully, we can see often that they're deeply relaxed and they don't have a lot of muscle movement. Sleep paralysis is more common for people with narcolepsy type 1, and it often does not exist by itself, but exists in association with vivid dreams, which are historically called hypnagogic hallucinations, because they can be so vivid and scary and hard to tell from real events. People can wake up in the morning and say, did I really do that? And it takes them a moment to figure out, no, that was just a really, really powerful dream. And sometimes patients come to us for treatment or for testing saying, I have the wildest, most disturbing dreams. And then we take a closer look, we do the testing, and find that they have narcolepsy and maybe even have had subtle cataplexy that has never really gotten much attention. Disturbed nocturnal sleep. Boy, this covers a lot of ground. Very seldom does a person with these disorders have trouble falling asleep at the beginning of the night. Most often they are exhausted and they fall asleep immediately. But what happens, and this is particularly cruel, is they can't stay asleep. And they wake up again and again, maybe because of dreaming, maybe just because of fragmented sleep, maybe because of sleep paralysis. There are a lot of reasons why they may wake up. In children, we worry a bit more about REM parasomnias, and we do worry about sleep apnea. So there are lots of reasons that a person can have disturbed nocturnal sleep, but this one can really affect a person's quality of life. But the good news is it's also something that we can use to inform our treatment. So sometimes when we say our priority for you is to help you sleep better at night, we select a medication that targets that, and all of their symptoms get a bit better. So it can be a door to improvement, as not just a symptom. So now, that was all about narcolepsy type 1, narcolepsy with cataplexy. This is where I start heading into the domain where we understand, but not as well, narcolepsy type 2. And so I'm just going to put my slide up and cross out the cataplexy part, because we tend at the moment to group these together and just say these people don't have cataplexy, or maybe if they're young, they have not yet developed cataplexy. So they're one of these people where the symptoms started, the sleepiness started, and maybe in the future, cataplexy will start. But in the meantime, we put them in this category, narcolepsy without cataplexy. Now, idiopathic hypersomnia is the same. If you say, wait a minute, you didn't change your slides. I didn't change my slide very much. Well, I did a little. Let me highlight what I did change. That these patients often have more trouble at night, where they will say, I make sleep a priority. My life revolves around sleep. I am in bed for 12 hours, 14 hours, and I still feel absolutely wretched when I wake up in the morning. I have a hard time waking up. I am late for everything in the morning. That's a little more specific to idiopathic hypersomnia. And the other thing that's specific to people with this disorder is they can take a nap And unlike a person with narcolepsy who often can take a power nap and say, okay, my battery's recharged, I can now get an hour of concentration and improved performance, that's something a person with idiopathic hypersomnia lacks. And where does a person with narcolepsy type 2 fall? Well, probably, that's really hard. There isn't a lot of data on that. So that is the landscape of the symptoms. But you can see I spent most of my time talking about narcolepsy type 1. So here they are, laid out on a spectrum. So narcolepsy type 1, quite a bit of science, quite a few interesting basic science studies and clinical trials. Narcolepsy type 2, we've historically grouped because they have the common denominator of dreams being abnormal. And then idiopathic hypersomnia has been over here, and it's really been kind of an orphan, not well understood, and until recently, no drug approved by the FDA. And I would often be feeling pretty sad in years gone by if we diagnosed someone with idiopathic hypersomnia, because I knew we were about to start a fight to say to an insurance company, this person has a real disease, they are really impaired, but we have no approved treatment. And as I stand here now, we have one approved treatment, as opposed to narcolepsy where we have multiple. So there's a real difference there, but at least we have one approved treatment. And in the future, we may sort of put narcolepsy without cataplexy a little closer to idiopathic hypersomnia. We'll see. But that's sort of, how do we lump things? That scientifically it's important, treatment-wise, for treatment selection it's important, but I don't know that it's that important for those of you who live with these diagnoses, other than, there was an excellent question at the end of Chad's session, can you have both idiopathic hypersomnia and narcolepsy type 2? Well, really not, but your diagnosis based on the test data could swing back and forth, and that might mean that the medications that your insurer is willing to pay for would be influenced by that. If your insurance says, which is not unusual, we will pay for FDA-approved medicines, period. Well, that could really affect a person's treatment options. So how do you make the diagnoses? Dr. Ruff went into this. First, you want to make sure a patient is well rested and not sleep deprived in any misleading way. And then he was talking about the MSLT, the multiple sleep latency test, but I'm going to go into just a little more detail as to what that is. I often call that the nap test, where we have a person who's well rested, who usually has spent the night before with us, and we have allowed them to get all the sleep they can get, even if that means having them start early or end late. And then we say, we invite you to spend the day with us, and you're going to take 4 or even better, 5 naps. You'll probably be here until the evening. Those naps will be 2 hours apart, and we're going to measure your brain waves, your eye movements, and your muscles to see if you enter dreaming sleep, and to see how quickly you fall asleep. So it's really a measurement of a symptom, measurement of sleepiness. So that is the key test. Now, Dr. Ruff went into the CSF test. I hope that in the future I'll have more to talk about when it comes to testing than I do today. But that's really the accepted, widely available test. CSF testing does exist, but for a person without cataplexy, it probably isn't a reasonable test. And even for a person with cataplexy, if they have a positive MSLT, I don't usually see the need to do a lumbar puncture. Once in a while, there's a reason to do it. But the MSLT is still, at this moment, the key test. So let me now talk about the very basics of treatment. What are our goals when we treat a person who comes to us with one of these disorders? I want them to be able to follow their dreams, to perform, to function, to have relationships, to go to school, to work, to drive a car. That's what I hope that where we can go. So many of those things require good alertness. And so most of the therapies we're focusing on, does this help you be wider awake and less sleepy during the day? Now, we can do that by giving a medicine generally in the morning that perks a person up, stimulates them. But we can also do it by giving them a medicine at bedtime that improves their nighttime sleep so they wake up more refreshed. I often use the analogy of a battery. Their battery is recharged, and then they have the promise of a better day because they're starting with a fully charged battery. Now, for a few patients, as I've already mentioned, the most distressing part of their problem is these horrible dreams. That often goes hand in hand with people who don't sleep well, so we often sort of group them together. Much less common are people who say, the sleep paralysis is just so scary and so frequent, I need help with that. We often group that in with the people with poor sleep and with very bad, scary dreams. And then sometimes, but not as often in my experience, a person comes in and says, the cataplexy is in my way. Sleepiness isn't so severe, I can deal with that. I sleep, I believe, pretty well at night, but the cataplexy is just something that causes me to avoid situations. I'm not going to, take on a certain profession because I'm afraid I might have cataplexy, or my employer won't let me do things because of my cataplexy. I had an interesting patient about a year ago who was a junior high teacher, middle school teacher. And she, I think, had a really raucous, difficult class. And her class noticed that if they pushed her buttons in the right way, she would have cataplexy. And so she was one of these patients. Now, she did have a few other symptoms too, but she said, my principal doesn't believe me when I tell her I can't prevent this. And so she came to me because of the cataplexy, because she said, I can't control my classroom. And my employer, I wrote letters to say, this is part of her disorder, but the principal didn't seem to be very good, ironically, at learning, because the principal still seemed pretty skeptical, and she just said, you're not a good teacher, because you let your kids get out of control. But what it was happening, actually, sadly, was the kids knew how to get her to have some cataplexy, and then all mayhem broke out. Very difficult. She eventually needed to move into a different teaching job. I actually wonder if any teacher, even one without narcolepsy, could have controlled that particular group. But so that was the end of that rather sad story. So when it comes to controlling symptoms, regardless of whether they are daytime alertness, poor quality or strange nighttime sleep, or cataplexy, it is important to sort of do the basics, to avoid being sleep deprived. I once had a patient with cataplexy and narcolepsy who wanted to go into law enforcement. And that requires a lot of night shifts, disproportionate night shifts, because that's when the mischief happens. And in the end, she took another career path, and she was a young adult, so she was still able to make choices. And I just worried, and I hated to, I worry that you're going to really struggle. Maybe with treatment we can overcome this, but to be a police officer in a squad car at night on the street with bad guys sort of hiding around, probably really tough career choice, and she opted to do something differently. But avoid sleep deprivation. Do all you can to have as good sleep as you can, but you may not get there without medication. Have a consistent sleep-wake schedule. So if possible, without sacrificing your dreams, don't go into a career where night shift is really inevitable. Try to be in a more stimulating environment where there are just things around you that help you stay awake. I had another patient with idiopathic hypersomnia who was a brilliant man, but his career was in designing maps. And his work site was to use a very special kind of piece of equipment in a dimly lit room looking at these maps. Oh man, sitting down, dimly lit, high focus, no movement. Now he was well into his career, so there, I couldn't say, really, is this the best job for you given your sleep disorder? But that was really tough because he was not in a stimulating environment, far from it. And then, if people can, and here at this meeting we always have a nap room, plan on a nap, a power nap. That is if you have narcolepsy type 1, perhaps if you have narcolepsy type 2, probably not if you have idiopathic hypersomnia. Scheduled nap is not going to be your ticket there. So if we just divide this into 3 categories, daytime alertness, nighttime sleep, and cataplexy, there are many options. And I actually modified this slide at the request of the conference. I had all the options listed here, and they said, "Ooh, you're stealing Dr. Thorpe's thunder." So if you see this and say FDA approved, but there's nothing FDA approved, that was as a result of me modifying my slides. This is a little misleading, so maybe I have more of a comedy act here than I realize. But there are many options that are FDA approved as stimulants. So modafinil, Provigil, armodafinil, Nuvigil. I'm doing what Dr. Ruff did, is disregard the instructions I've been given. There is, Adderall, which is an amphetamine. There is solriamfetol or Sunosi. And then there is pitolisant or weight kicks. So there are quite a few that target daytime alertness. And these are generally taken in the morning. There are some old-time sleep doctors who have an interesting trick in their bag that I use once in a while, which is to take the stimulating medicine at bedtime so that it's in a person's body and it's there to help them wake up. That's not very conventional, but I do want to say that stimulating medications, once in a blue moon, are not used in the morning, are used at night. And there is a delayed release form of methylphenidate, not FDA approved for narcolepsy, but approved for ADHD, that we sometimes will use when all other things have been tried and not effective. So a knowledgeable treatment team will have a few tricks up their sleeves. We prove that these medicines work by helping a person be more alert and ideally concentrate well and perform better with simple tools that are a bit unsatisfying. The Epworth, most of you will have filled that out countless times. Boy, that's not a great test, but it is what I have to point to as I stand here. I hope we get better tests. And the maintenance of wakefulness test, which is the opposite of the MSLT. Instead of saying to a person that we are going to have you take 5 naps, we say we're going to have you be awake 4 times, and the sessions are longer. This is not done much in clinical practice, but it is what the FDA relies on to prove a medicine is effective in helping a person be alert. So it is important in clinical trials. If any of you have participated in clinical trials, very few sleep disorders do the maintenance of wakefulness test very often, and it's pretty painful for a patient because if you're well treated and you're proving you're well treated, you're there for 40 minutes not allowed to do anything, and then you get a break, and for 40 minutes you're there awake. The good news is you're passing the test, but you can be bored to tears in the process. So for reducing sleep paralysis, I'm wondering where this is. Okay, for reducing sleep paralysis, we generally will use a sedating medication at night or occasionally off-label an antidepressant, which you heard Dr. Ruff say, antidepressants get in the way when we do an MSLT because they can push back the REM. Well, sleep paralysis is viewed to be a little bit of REM showing up where it doesn't belong. So an antidepressant, which can be used for a person without depression, can push back that bit of REM and help control the sleep paralysis. For extreme dreaming, we tend to rely on sedating medicines, and I tend to rely on the oxybate family of medicines to help a person just have more stable, continuous sleep. Occasionally, if for some reason a person can't use oxybate, or in the past, before oxybate medications were available and were available in their newer forms, we would use an antidepressant, just kind of like the sleep paralysis. Now, occasionally, we try to boost daytime alertness by improving nighttime sleep. And this is where the oxybate medicines really come in. where we try to have more stable recharge time for the battery. A person is fully charged in the morning and then is able to function. And you can see, so we do some strange things. We use a sleeping pill to cause sleepiness to lead to alertness. That requires a little bit of thought. Okay, how did you get from point A to point C there? But that is the science of treating narcolepsy, and it works. So cataplexy, the small number of people, like my middle school teacher patient, where cataplexy is just a huge problem. First of all, we try to have them be wider awake. Many of you have probably had this experience. You're just beat. You've had a long day, and then you watch a funny show, and you have a little more cataplexy than you might have under different circumstances because the sleepiness makes you more vulnerable. So if we can treat the sleepiness, often the cataplexy at least gets better. But we can use a sedating medication at night. These appear to be quite effective for cataplexy, in part because they stabilize sleep and they sort of help the REM sleep go where it belongs and not pop up where it doesn't belong. And then also, just like the sleep paralysis and the hypnagogic hallucinations, the extreme dreaming, we can use an antidepressant off-label. So the next question is, I've been mostly talking about narcolepsy. What about those of you who have idiopathic hypersomnia and your big problem is excessive daytime sleepiness? Maybe first thing in the morning, maybe all day long, not so much the other symptoms. This is where we are off into the unknown. There have been studies, as Dr. Roof shared, where the thought has been if you turn off the GABA system, a person with IH will be wider awake. But those studies have yielded mixed results. More work needs to be done. I think we may find that there are different systems at play here, but we also may find that some of our familiar medicines will help patients with idiopathic hypersomnia, even if they have a slightly different cause. And this is quite common in medicine, that sometimes we use a treatment that reduces symptom burden, even if that treatment doesn't directly address the underlying suspected theory of why the person has the problem. It still helps them, so we use them. And I'll point to the antidepressants. Antidepressants help the symptoms of cataplexy, of sleep paralysis. We don't, so we're using a medication developed and tested for other purposes to help people with narcolepsy. It requires a little more skill and knowledge on the part of the provider and a little more faith and trust on the part of the patient, but it works. I always like it when we have more science, but sometimes we just have to do our best with limited science. So why does narcolepsy cause excessive daytime sleepiness? This is better understood than for IH. For a normal sleeper, they have the pleasure of going to bed and more or less sleeping for 8 hours. They have a cycle where they go in and out of light sleep, deep sleep, both of which are non-dreaming, and then dreaming sleep, and they repeat that over the night. But a patient with narcolepsy, it is just all mixed up, especially narcolepsy type 1. So I'll show you some pictures of this. These are two patients of mine. The patient on the top is not exactly a normal patient. This is a patient with IH. And this is an older image when we still believed there was such a thing as stage 4 sleep. Now we just talk about stage 3 and we combine those two. But you can see with this image, and let me see if I can find a pointer here. And that doesn't show up for you. If you look at the beginning of that study, you can see that it sort of goes up to stage 3, and then the person wakes up in stage 3. And if you think of this as a skyline, the first skyscraper is well into the night. Now look down at this other patient. This was someone with very frequent cataplexy. She had narcolepsy type 2. As soon as she fell asleep at the beginning of the night, bam, she entered REM sleep. And she had something else that's not entirely common and well disturbed, is that she couldn't stay in REM sleep. She had so much sleep instability that she's dreaming, not dreaming, dreaming, not dreaming. So you can see if you compare the block of REM sleep between these two people, look at the last one on the right-hand side, that's a nice solid block. That person has a long stretch of dreaming. The person with narcolepsy type 1 is really flipping in and out. It's like she's got 20 slivers. Well, there's a lot of potential there for sleep paralysis, for hypnagogic hallucinations, and it's all tied into the REM phenomena. So we do understand the bottom patients. We don't so much understand what's going on with the top patients. So this is what it looks like on a sleep study to enter REM sleep. This is from an MSLT, a patient with narcolepsy type 1. On the left hand of this slide, the person is in non-dreaming sleep. And if you look at the chin, CHN, you can see there's activity being detected by the monitor. And then something changes about halfway through. Suddenly, there's no muscle activity. That person has entered a state of deep relaxation that we actually consider almost like paralysis. And it means that we're different than dogs, where you can tell if you're a dog owner that the dog is enjoying their dreams, or at least is having a dream of, eating something and their whiskers are moving. And you can sort of read the dog's mind in that one setting. You could be watching me sleep, and I might be dreaming of a wonderful meal, but you wouldn't see my whiskers moving at all because I am deeply paralyzed and I don't have narcolepsy. But here, this person is entering, and I don't have REM behavior disorder. This person is entering REM sleep, and if you look at the top, LOC, that's looking at the eye movements. There isn't much going on there until the halfway point, and then, wow, lots of eye movement. So this is a person switching from non-REM into REM, and this is what a person with narcolepsy does frequently, inappropriately, during the night, during the day, and that's what we're trying to control when we try to control the symptoms related to these brainwaves. Now, this is a fairly similar slide, but actually quite different. You'll see there are lots of eye movements there at the top. Well, this is a person who's awake, and they're actually, when we were trying to develop this cataplexy test, they're watching a video that's kind of a funny video. And if you remember what the last one was like, this is a person who started to laugh, and look at the chin EMG, suddenly it goes flat. And this is a person who is having cataplexy. And if you go back to that last slide, what happens at night for a person entering REM sleep looks actually, especially from an EMG standpoint, pretty similar to this person who's awake but having a brief episode of cataplexy. That episode of cataplexy is about 20 seconds. So, why is it that sleep is not more continuous in narcolepsy type 1? Why are people waking up and switching out and switching in? The research shows that this is truly an example of a chemical imbalance. I'm a psychiatrist by training, and psychiatrists spend a lot of time saying to people, you have depression, you have anxiety, we believe there's a chemical imbalance. Let's now use our medicines, generally antidepressants, to treat that chemical imbalance. However, for me as a sleep doctor, I go down the same path. You have narcolepsy. Your sleep means that you're waking up all the time during the night and you're falling asleep during the day. It's very fragmented. You have a chemical imbalance. But the astonishing thing for me is for people where this is appropriate, we can prove it. By doing the lumbar puncture and measuring the orexin level, we can demonstrate the chemical imbalance. And by observing a person in those rare occasions where I witness cataplexy, I can see the evidence of the chemical imbalance. So although I know it's frustrating to have a disorder that's not well understood, at least some parts of narcolepsy type 1 is better understood relative to some other brain disorders. We have a long ways to go, and for those of you with idiopathic hypersomnia, I wish we had a similar degree of understanding, but we'll get there. We've made headway, and we're not stopping. This is a slide that you saw earlier, so I won't go into it much, but you can see there's a difference. So again, chemical imbalance, not just theory, and we are very grateful for patients who donate their brains so that after their death, we can do this type of research. And Mayo Clinic doesn't do this, but scientists at other places, this requires a great deal of skill. These tend to be extraordinarily well-trained neuropathologists who do this kind of work. But we can, again, demonstrate there's something very, very clearly different about the brain without all of those dots and the brain with all of those dots, and it links to this orexin hypocretin system that you heard about in more detail earlier today. So the chemical imbalance is something that we know about, and I hope that in the future we'll have more tools to treat it. But we do have tools. Some of them we have adopted from other disorders, and some of them are getting a little closer to the real chemical imbalance, although so far we have no orexin medicine, but someday I think we'll be there. So why is hypocretin or orexin low in narcolepsy type 1? It is believed that at birth those levels aren't low, or to go back to Dr. Ruff's talk, why are they maybe silenced as opposed to being vocal and busy and helping people stay awake and sleep at night? Narcolepsy type 1 most commonly starts in adolescence. So to go into what you've already heard about earlier today, there seem to be three things combining. There is a genetic predisposition, which is the HLA, and I'll just show you here a chart showing people with narcolepsy and cataplexy have a high rate of that HLA, DQB10602, and some other ones that to a lesser degree. And people without cataplexy to a lesser degree. And then the general population, still many people have it, but not nearly as many. So there's the HLA, then there is age. And I'm just going to talk about that for a minute, and that's where these graphs come in. And if you looked very closely at Dr. Ruff's graphs, you would have seen that even with the, some of the epidemiologic data about virus exposure and vaccine exposure, younger people, teenagers, seem to be more vulnerable. And this is data from Minnesota showing that the age of onset for cataplexy is very common during the teenage years. Here's some more, this was from Japan, and this is from Minnesota. Different parts of the world, similar findings. So there's something about being young, doesn't really matter if you're male or female, but young, having a certain HLA, I think of it as a fingerprint. If you've got that fingerprint, you're a little more at risk, and then being exposed to something. And we don't know what the exposure is, and of course there's a little debate, is that really correct? But there's quite a bit of evidence on this. So something tricks the brain into reducing the supply of orexin or hypocretin that then leads to REM sleep being very unstable, and a person entering sleepiness during the day and entering wakefulness at night. And what we have to do is stabilize that. So you heard about this earlier, 1 out of 2,000 people are known to have narcolepsy. And here's the general population. This is some old data, but it still applies. So there are a few families where the risk is higher, but there aren't many families like that. For most people, they don't have any family members who have narcolepsy, but there are a few exceptions to that. So last but not least, can we come up with a better, more elegant solution to truly treat this chemical imbalance? Right now, we're sort of treating the symptoms with medicines that help stimulate the brain so you're awake at night, help produce deep, continuous sleep without as much flipping and flopping, so a person's REM is a little more orderly and doesn't happen as early, and their dreams are reduced, and then they wake up recharged and ready to go. But there certainly have been efforts to come up with medicines that may directly address the orexin system. So stay tuned. We'll see what happens in the coming years or maybe even months. There are multiple groups working on this around the world, so we'll see what happens. But in the meantime, there are an array of medicines available, not so many for idiopathic hypersomnia, although maybe there will be more, because some of the medicines currently approved for narcolepsy might be demonstrated to help idiopathic hypersomnia. So even though we don't know what causes it, we may have treatments that will be effective. So drugs are being tried. We haven't given up. People with idiopathic hypersomnia often felt a little overlooked, and I hope that that feeling will fade a bit, because there's a lot of interest, a lot of effort to try and reach that group, not just those with narcolepsy. So I hope that this was helpful. You had the sleep medicine specialist version of this first, and now I've tried to take you down to the basics, and I hope that the combination of these two lectures will lead you with sort of a deeper understanding of what these disorders are, what their symptoms are, how we treat them, how they are alike and how they are different. And I hope in the coming years that I can return, or someone can return in my place and say, we have new tests, we have new medicines, or we have a better understanding of the existing medicines. I'm quite optimistic that we're headed in that direction. Many of you will see outside our exhibitors who have products that are FDA approved. They're only allowed to talk about the FDA approved things at a place like this. But be aware that there are clinical trials where they are thinking about how can we use these approved medicines for new things, or how can we develop new medicines. And if you are eligible, please consider participating, because that's the way there will be more for me to talk about in the years to come. Thank you very much.